As the screen says, this is the start of Lecture 8. This is the second lecture regarding the respiratory system. I think this one also might be a little shorter, and I just want to say this at the start. What I'm going to be talking about is the upper respiratory tract and beyond the pharynx, the pharyngeal regions, and it's largely a lot of anatomy. I'm going to toss in some functional significance here and there and make some analogies, but I'll move pretty quickly, counting on you to simply study the anatomy and to become familiar with the anatomy with the benefit of these recorded lectures. So these recorded lectures will allow you to study the screen. Also, most of these figures are also in the textbook, but I remind you that the cadaver pictures with the highlighted regions are not typically in your textbook. I don't believe so. And so this is an especially good tool to look at this recorded video to learn that highlighted anatomy. Okay. The larynx. The larynx, first of all, is sometimes called the voice box. You would guess that it's in fact where we are generating sound, and I'm using it right now. And as fun as it is, at some point here in the lecture, I'm going to explain how it is that we make sound when we talk. And it's more than your vocal cords. It is, as I had said before, a shaping of that sound by the shape of the mouth and also the diversion of sound more of a nasal kind of an area or deeper into your throat or more at the tip of your tongue. Okay, so we'll talk about that. The larynx and most of the structures we're going to see today are cartilage. There will be one exception. There's one bone that we'll talk about today in the passageway from the pharyngeal regions down to the deeper recesses of the lungs, and see if you can figure out what bone that might be. Your hint is it's an unpaired bone, which means it doesn't have a right or a left. It's along the midline. One of the main functions, as you can see, of the larynx is separating the passageways of whatever we're putting into our digestive tract, so that's largely food and drink. And likewise, in some organisms, like us, but as well, organisms that don't necessarily speak and use a language like we do, but perhaps make other noises, perhaps high-pitched noises. Some of them involve the larynx just as well. Us speaking is phonation, so can you think of any animal that does this? Well, just shout out your answer. See, that's funny, because if you shouted out your answer, you would be doing this, and that would answer the question, and I'm not even amused by my own jokes anymore. Well, maybe that one. So here we've got that highlighted cadaver. I'll allow you to freeze this image and study it in some more detail. I'm truly delighted by this assemblage of images that are recorded for you to be able to review. You can come back and look at things as you understand the larynx better by what I'm going to say here in the next few minutes. And later on, you can help to understand this. And I'm also delighted to have such high quality images of a real cadaver dissection. That will be important for those of you that go on and have the chance to study and work with real cadavers. So here's some just beautiful images of highlighted color on the right and on the left, showing you some of the musculature that's associated with the larynx. Again, the voice box. This is the wide part just below someone's chin. It's going to go up and down as they speak, as they swallow, also as they're nervous. So I don't know if you've noticed when people get really, really nervous, if you ask them a question, it's sometimes even an expression that people say, wow, that made me swallow hard, right? So if you ask, I don't know, whatever tough question, are you going to be able to pass that exam? And if you're nervous about it, you might swallow. It's one of the things I pick up on sometimes when I talk to students and notice things about them where you're communicating if I watch the body language and your general physiological responses, like getting all red or turning quite pale. Here's now figure 22-4, and this is in the 8th edition, but probably true about the 7th as well as the 9th. And we can see in the sagittal section some of the deeper structures associated. So here we've got a vocal cord right here. Some of the other cartilages that you've learned about, arytenoid, for example. So you got epiglottis right here that's going to close over but it's going to come into the region of these arytenoid cartilages. So that's an arytenoid cartilage right there, and the corniculate cartilage right at the very, very tip. That's helping to close, so the epiglottis is going to come down and close, sending whatever's in this region instead down the esophagus instead of the trachea. This is anterior side, so with your own fingers right now, you can find the bigger lump, your voice box. You should be able to palpate this. The biggest piece is the thyroid cartilage. If you swallow, you can feel it go up and down. And then if you work your way farther down, so down to about where your two clavicles are coming together, meeting your manubrium of your sternum, in that region you clearly have then the tracheal cartilages down in here. So we'll talk about some of these structures and functions, and here's the answer to the question. It's all cartilage here and other things like connective tissues and muscle and epithelia and blood vessels. But here's that bone, that single bone cut here in the sagittal section, and that's the hyoid. It's not articulating with any other bones. There are other bones that are sort of free-floating and connected by tendons, like your kneecaps, the patellas. But this one is really quite much more independent. So epiglottis right there, as you can see, almost vertical. It's pulled down, as I said already, when you're swallowing. The tongue is helping to push down the epiglottis. These are all things you can read in this box, so do look at this box. Of course, when the epiglottis is down, that's helping to close off the trachea, and then whatever you're hoping to swallow into your stomach. So beverages and foods are going to make their way down the esophagus, which is going to be on this right side of this imagery. Okay. Now, if you slurp, if you've got some hot beverage and you're slurping, you know, I don't have a beverage with me right now, but if you sort of suck in the beverage, you can see the potential for choking. And it's very high. And it's one of the things that I've done for most of my career. I've brought a hot beverage with me to lectures, and in front of the whole class, I've often choked. So I'll sip something in and aspirate. I'll pull air in, trying to pull a fluid in. And the problem is, once it gets down into this laryngeal region, you got to separate out the fluid you just pulled in from the air you're pulling in, and you can potentially choke. These vestibular folds over here on the side are helping to also channel food and beverages. So, when you hear the phrase, oh, somebody's choking, they're coughing, and they make the comment, it went down the wrong pipe. This is the pipe. It probably went down right here and not the esophagus. That's what we're talking about. So beautiful views also found in your textbook, so we don't need to spend a lot of time here. You can study those on your own. Some more additional details about the larynx. Lots of cartilage, as we said. Notice that the thyroid cartilage is the Adam's apple part. It's larger in males because its growth is affected by male hormones. And males typically have more male hormones. Other cartilages that we've talked about, and you can go back and take a look at these diagrams and think about these functions. Ligaments that are helping to hold these parts together and hold them to the hyoid. Just again, looking at these different components. Go back one real quick. So you got different membranes, different labels down here to study. Likewise, in the next diagram, I don't believe these are in your textbook, so I again really pleased that these are recorded lectures, and now you have a copy of these images that help you to understand what we're talking about. And I cannot tell you how much better it is to be a student of human anat phys now versus 30 years ago. You guys have this kind of technology, right? You're watching YouTube, you're watching a recorded lecture, you're watching your instructor at Blackburn narrating these kinds of things with really beautiful, like this, color-coded anatomy. Versus 30 years ago, black and white images on a printed page. Okay. So guys, it's almost too easy. And I hope you really do study these things and don't look quickly, because you can really appreciate the anatomy better than ever. more highlighted regions just to help you make sure you thoroughly understand. We're going to come and talk about these parts in just a minute. So here are vocal cords. Vocal cords right here in the little box. Vocal cords are going to come together, and then as air is being passed between them, these edges are going to vibrate. The opening here is the glottis, and it includes, of course, the vocal cords, and so that collectively is called the glottis. Okay. So epiglottis, what do you think epiglottis means? And that was the name of the cartilaginous flap that's going to come down and block this area. Epi means above. Okay, so the epiglottis, go back and look at that diagram. Maybe if you can flip back or take a look simply on page 850 of your textbook. And there you can see the diagram of the epiglottis. We said that was almost vertically oriented, and it's above the glottis. So this anterior wall has the vestibular folds. That's these guys right here on the sides. As it notes, this is not involved in controlling speech, but it does help to close up this laryngeal region during swallowing and help to block food or any drink or something going down the wrong way, right? Vocal cords are producing a sound. Air passes between them. You can see there's a rounded edge, so that's the likely location of the vocal ligaments. Covered with a stratified squamous epithelium, but it's not keratinized. You can see it's wet. And of course, it's going to vibrate, right? So the analogy often used is if you have let air out of a balloon and you pinch the neck of the balloon as the air is coming out, it'll make squeaking noises. And you can pull or not pull on the neck of the balloon and the sound quality changes. And that's a good analogy to how your vocal cords work. Okay? So air force between the vocal cords causes them to vibrate, as you can do with the neck of a balloon. If you pull that neck really tight, the sounds are very high. And then as you loosen up the neck of the balloon, the sound goes down. If I were there with you, I've often brought in balloons and allowed you to do this and feel that and have that experience of those vibrations. Okay? Well, why do male voices typically sound different than female voices? Because overall, on average, of course, there's an overlap in the size and shape of men and women and their anatomy, of course, and it's related to the hormonal differences between the biological sexes. Male vocal boxes tend to be bigger, and by bigger, they're going to be longer and thicker vocal cords that vibrate more slowly, and more slowly is a lower pitch, a lower sound. And a really high pitch, okay, is really tight. The loudness, and yes, I'm aware that I'm a loud man. So was my dad. So is my son. Okay? Things that we, the males of the Zelisko family, things we normally do not hear people say to us, include, could you talk louder? Okay? Yeah, we're loud. Not sure why, but you know, it's a good respiratory tract. That's all I can say, because we're forcing a lot of air between our vocal cords. Vocal cords are producing the beginning of the sound, but again, much of that sound is formed by, as I've already said, when I talked about the pharynx and the mouth, and nasal regions as well. So I would add nasal cavity here just as well. So how much air and sound is diverted through the nose? That's part of how we sound. And that sound is not only speech, but also singing. Here, just looking at some of the mechanics of what's moving when in fact we're pushing the vocal cords apart or allowing them to come together. And the diagram's there. This is on page 851, and you can study that in your book. This is a sagittal section that looks an awful lot like the model that's in the lab that will be on the lab exam over the digestive system. and of course the overlap here with the respiratory system. When we take a look beyond the larynx now, taking a look at the trachea, which is the next, so here's the laryngeal region, and now beyond that expanded region is the trachea, farther down. Okay, it's variously, says about 4.5 inches long, so it varies, and people have different neck lengths. Neck lengths largely determined by the length of the vertebra, so variations here, but other factors just as well, like the thickness of the intervertebral discs right here. Okay. Trachea and laryngeal regions are anterior to the esophagus, that's what we've said already, and the trachea is held open by a series of C-shaped rings in which the opening of the C is on the side near the esophagus. We're going to see about that, why that is. What is the functional significance of these C-shaped rings? It keeps open the airway. And I'm going to talk more about this, but we move air into our lungs under negative pressure. So the trachea could collapse, and we have to keep that open. So sometimes people confuse the trachea and the esophagus. The esophagus is a flexible muscular tube. It doesn't rely on air pressure. But the trachea has to be held open, and it has to have some kind of internal network. Okay, so here we're looking at now the trachea, so laryngeal region, and trachea and C-shaped rings right here. And the C-shaped rings are joined in the back by this muscle. This is hyaline cartilage that's forming these C-shaped rings, and if you were in cell biology studying hyaline cartilage, it is routine that the slides that you study are this particular cartilage, hyaline cartilage, in the trachea. What's kind of fun about that is it maintains a nice steady shape, so when you have sections of this, it's easy to see. It's also an excellent example of a pseudostratified epithelium here that's ciliated. And so here you can see that epithelium, and there's the cilia, and there's the mucus on top. So, trachealis muscle here in red, right here, is spanning this opening. We just said that already. And it has two main functions, right? One is the gap here allows a little room for the expansion of the esophagus while you're swallowing. So if this were all cartilage all the way around, it would impose on the esophagus, which would be sort of the oval shape right here. But function 2 is, by having a sort of flexible C shape right here with a muscle, a contracting muscle, what would happen? What would happen if this trachealis muscle is contracting? And the answer is the lumen of the trachea would get smaller. Okay, so the trachealis muscle relaxed is the largest diameter, contracted narrows it. Back to those tracheal rings for keeping open the airway. I regularly make an analogy to the rings that you see in the hose of a vacuum cleaner. And this is about the best analogy I've ever come up with. And here's why. Because the structure of a vacuum cleaner hose, consisting of a series of rigid rings, but a series of rigid rings, not just a solid tube, keeps this tube open and furthermore allows the tube to be flexible. So what would be the case if your trachea was a solid tube, like a piece of pipe? And the answer is when you bend your neck sideways or forward, you would be restricted by your trachea. So what we have instead are a series of rings, cartilaginous, hyaline cartilage rings, that keep the trachea open. But by having a series of rings going up and down the trachea remains flexible yet open. And flexible yet open. And both of these, vacuum cleaner hose and trachea, are functioning under negative air pressure as air is pulled into the lungs. Now, it also is one slight difference, and that is air is also forced out of the lungs so that we can exhale forcefully. And that's generally not the case with a vacuum. However, depending on what kind of vacuum you have, like a shop vac, on a shop vac, the thing that looks like a big can with, it uses a vacuum cleaner, a shop vac, you can actually switch the hoses sometimes and use it to blow air out. So that's pretty neat. So it's a really good analogy. Here, now taking a look, just highlighted areas of the trachea. And so see if you can remember this. What was the name of this entire region right up here? And it's the laryngeal region, or the larynx. See if you remember what this structure is right here. And the answer is it's the hyoid. And can you remember what this cartilage is right here? And the answer is thyroid cartilage. And what was the name of this vertical structure right up here? And the answer is epiglottis. Okay. Here now, we're taking a look at a cutaway of a cadaver dissection, so a figure, again, not in your textbook. So really happy again that we got this for you as a recorded lecture. This would be where the air is coming in straight, and then it's going to be diverted into one of two channels, to the right and left lungs, because this is a ventral view. So here we're looking at the trachea, and this little carina, this pointed ridge here is the diverter that is helping to channel air to one of the two sides. A carina is a ridge that's pointed. There's a carina, if you've ever carved a turkey and a turkey breast, the very, very front of the turkey, where you have right and left sides that are white meat, right in the very middle, well, that's a carina just as well. Okay? If you had a ridge on the body of your sternum, that would be a carina. Most people don't. Right? Somebody just told me that they thought they saw a picture with somebody with such a ridge. This, again, is inside the air passageway. This is not a ridge on the sternum. Okay, see, it's been cut away. How about the lining of the trachea? We saw this figure before, but we didn't really talk about it. So what we're looking at, this is cranial, and that's caudal, so this is inside the trachea. Here's a real image of that. So goblet cells here, pseudostratified epithelium, so the nuclei appear that there's two layers, but in fact it's just all cells that touch the basal lamina and touch the lumen. And here we can see the very base of cilia. This is actually part of the cytoskeleton that anchors the cytoskeletal elements in cilia, which are microtubules. And so here's a whole bunch of cilia in real life. Here's a bunch of cilia as tufts, and these are mucus cells, the goblet cells in between. That's these guys making the mucus. And so the functional surface right here is cilia covered by a thick layer of mucus. That's what I was telling you about before. Clear your throat. And what you're doing is helping to bring that mucus all the way up, and then you swallow it. So the cilia are regularly moving mucus upward. As you breathe in, there's turbulence in the air, and particles are spun around until they stick, hopefully, to the mucus. And in a healthy respiratory system, this is helping to remove particles that have been inhaled. Now, a couple things for you to know. Cigarette smokers find that this pathway, this conveyor belt, is slowed. And so one of the things that happens is smokers are all during the day having trouble. They're inhaling extra particulate matter, just crazy. And they are suppressing the mechanism that removes the particulate matter. Okay? Well, most smokers, when they sleep through the night, do not wake up regularly to smoke a cigarette. So during the night, this system recovers a little bit, and now those cilia are able to move the mucus up. And then in the morning, when a smoker wakes up in the morning, they often hack, and they're just and then just coughing horribly, and they're removing a tremendous amount of just dirty, filthy mucus, and they must have the worst breath in the world. And that's because overnight, this elevator really here that's moving up the dirty mucus is starting to catch up. Why anyone on earth would choose to inhale pollutants and then suppress the very system to get rid of them it's an addiction, guys, right? So people start this habit for whatever reason, and then once addicted, like so many other drugs, alcohol, all kinds of other things that, like meth, for example, or crack, the people that are smoking things, eventually you're hooked, and even though you realize this is not a good idea to keep doing this, that's what it means to be addicted. You're stuck doing it. So here we see in the text now exactly what I just told you. A pseudostratified epithelium covered with cilia, moving mucus upwards. Here they call it the mucociliary escalator. I don't think this is the one that Trump came down when he announced that he was going to run for president. I think that was a different escalator. Anyway, this one's the mucociliary escalator, bringing particulate matter up. So it says debris removal, it's trapping particles in the mucus, the cilia is moving up. Now, one final point about this, and I see this and I just keep clearing my throat because I keep reminding myself about the system. I want to make one final, just clarifying something that's regularly a misunderstanding. Many, many times, people think that what is filtering as you breathe in is that the cilia themselves are acting like the teeth on a comb. That is not the case. The cilia are not combing the air. You can see it right here. The cilia are covered by mucus, and then the cilia are propelling the mucus up through the system. Okay? Cilia do not comb the air. Here in this case, in this preparation, this is a scanning electron micrograph of a surface. Here they've already cleaned off the mucus, so you can see the tufts of cilia and those goblet cells, the surface of the goblet cells. Here's the tracheal fork, the carina, I already said, is helping to direct airflow left and right. We're right near the end here. This is where a tracheostomy is inserted. So most of you know that tracheostomy would be inserted if somebody needed some assistance to get air in and out of their body, avoiding the passageway from all the pharyngeal regions down through the larynx, right? So we're below the larynx in the trachea, and here there's an opening cut here. Now, I want you to think this through. If somebody's had this, you can see the mechanism that's keeping against their skin, and then there's a little cuff that holds this hopefully in place in the trachea, and then there's a tube that's channeling air in here. So this would be obviously in a hospital situation, at least where it would be put in to begin with. Now think this through and think what would be the problems. First of all, you'd have an opening right here that isn't going to heal, and so that's always a source of an issue. You also could get all kinds of infectious agents, so germs, making their way in. But if you really think about it, we talked about the nasopharyngeal region as a place where air is moisturized and warmed. Well, the air coming in right here in this situation is not being moisturized or warmed. And so what's going to happen is dry air that's probably cooler than the body is coming in and irritating the lining of the trachea and also the lungs. And that can lead, over a long term, to some serious problems. And that's described right here. So it says, if left in for a long time, will dry out mucous membranes of the respiratory tract. They become encrusted. It's difficult to clear the mucus and thereby likely to lead to an infection. This is also the route in an emergency where if somebody can't breathe because they're choking on something, in theory you could stab this area, but boy oh boy, learning to do this to avoid the laryngeal region, to be a little farther down, not to damage the thyroid gland, you really got to hit the right spot. So I am not giving you the training right now on how to do such a thing. But you might have seen something in a movie like where they took a Bic pen, which is a firm tube with an opening, and they just stabbed it in the person's throat. A soda straw, like you get maybe at McDonald's, which tends to be hefty soda straws, that wouldn't hold up, right? that would collapse. You'd really need something stiff, like a pen, like the plastic sheath that forms some pens. Now, here we're going to follow this a little bit into the lungs, talk about the lungs, and then I'm going to bring this to an end. We're seeing where the trachea splits. We call those generally the main bronchi. Then they're going to branch further into the lobes of the lungs, and that's what we want to talk about first. So the upper areas of the lungs are the apex of the lungs. And I told you guys before in Human Anatomy Phys 1, if you feel within your clavicular region, so you got your clavicles, right? And so the adjective would be clavicular. And you push your fingers really deep in, and then you take a big deep breath, you actually could feel this part of your lung pushing up near your clavicles. Look at the 3/4 models that we have in the lab and notice that you can see this apex of the lung on both sides sticking up right there near the clavicles. It's that far up. Isn't that interesting? Yeah. Well, here we look and we can see a base of the lung that's resting against the diaphragm. So it's concave. Apex pointed up here. The costal surfaces, which are the areas against the ribs. So that's this outside right here. And notice a term here that I had introduced in the lab, mediastinal surfaces. I told you before the mediastinum was this central space encompassing the trachea and the esophagus and the heart and the thymus gland that's going to be located, and some nerves and blood vessels that are coming down, and I included phrenic nerves that come down and innervate the diaphragm right here. Okay. So just some basic anatomy. This is a heck of a cool figure. You don't have it in your book again. And boy, oh boy, if I were you, I would spend a lot of time on this image right here. So happy to keep saying it over and over that you have this recorded lecture. And so you have a copy of this image. And right now, freezing the frame and really seeing everything that's here is so important. So this is a person laying on their back. This is their anterior or belly side. This is their back. And for starters, let's get a little oriented. Right here in the middle are the vertebra. So this is vertebra right here. There's the opening, so the neural canal and the spinal cord within it. There's the spinous process. So if you rubbed your hand on the center of someone's back, you could feel that spinous process right there. Okay. Now, right and left, because the belly's up here, right, and you're laying on your back. And on the left side, left lung right here, you can see it, and on the right side, you can see the right lung. Then notice that there's a space, and that space around the lungs is called the pleural cavity. And pleural, this kind of pleural, not plural without an E, plural with an E stands for then having to do with the respiratory system. We talked about these linings, so the peritoneal surfaces before. Here we have a visceral pleura. So viscera means the organ. So the pleura that's covering the organ is the visceral pleural. And then here the parietal is lining the cavity. I'll tell you an interesting little story. It's a bit of a mystery. So I'm a little tangent. I don't tell too many of these, but it's a bit of a mystery. I got my third booster injection for COVID at the end of October. And for the Moderna vaccine, the third shot, the booster shot, is actually supposed to be half a dosage, not a full dosage. And in fact, Moderna since has looked at the antibody response from the half dosage, and they found that on average, the number of antibodies from the third booster shot went up 37 times. And that's with the half dosage. The full dosage on average went up 83 times. Well, when I got the shot, they gave me the full dosage, and it was a mistake. The full dosage is reserved for people, some people, who might be immunocompromised or have other problems. So Amy and I, my wife and I, both got a booster shot that was an extra strong booster shot, and we're hoping that means that we got extra antibodies and that'll last longer. Okay? Oh my gosh, so what does this story have to do with this? Well, and I haven't told too many people this because I don't want you to be discouraged from getting your shots. But I had the typical response. So this is the left side. So I have a shot in my left arm. And my lymph nodes, which, this is down at the heart level, so this isn't going to be in my armpits. But my lymph nodes swelled up on the left side, and that's to be expected. And I felt kind of crappy the day afterwards, like I had a bit of the flu. And then I got better on days 2 and 3. It wasn't too bad. On day 4, it was still pretty good, but I just didn't feel 100%. And in the middle of the night on day 5, I got a pain on my left side in my ribs. And if I'd sit up and just sit at a certain angle, it hurt. And if I change my angle, it hurt a little bit less. And when I slept, so the nights of day 5, 6, and 7 were tough nights sleeping because it hurt on my left side. Now, the fact that it hurt only on my left side was an indication that that was a side effect from the injection, that I'm having this kind of, immune response, even though it's not a real threat. It's a practice run, right? On the night of the 8th day after my shot, it all went away. When we tried to push, both myself and my wife, to find where does it hurt, when we push on these ribs, we didn't seem to find the spot. And my suspicion is that I had an inflammation response of the parietal pleura, or even possibly the visceral pleura, and that these two areas may be in contact and irritating each other as I breathed were painful. Now, I think it's probably more likely that the pain was the parietal pleura, because I had the pain even if I wasn't taking a breath. So if I'd exhale out and I still could move sideways, we'd expect that there'd be this gap here a little bit. And, actually it wouldn't be much of a gap here. And anyway, it seemed to be independent of how I was breathing. But it's a mystery. And I was talking to Dr. August Adams about this, and he and I can only speculate. But it went away, and I'm fine. And I hope I have extra antibodies. All right. More things to tell you. Okay? So you're back to the midline right here. There's the heart. Lots of parts of the heart, but we're not going through the parts in this diagram. And here's the aorta. And you're going to be studying this very soon. So the aorta already would have come off the heart, looped up, given off branches to your arms and your head. And then this is the part called the thoracic aorta that's heading down, sending blood down now to your abdomen. Okay. Right here is going to be, it says sternum. And then you got ribs coming off. This is musculature going on, and this person is not very fatty. So good for them. Lots of things in this image. Oh my gosh. It really helps to integrate different systems you've seen and are going to be looking at and studying. All right, the lungs. So some basic things here. Right lung, 3 lobes. Left lung, 2. Why 2 on the left? And we think that that's a bit more because there's the heart's a bit more on the left side. And heart tilts towards the left, says right here, occupies more space on this side of the mediastinum. Once again, that midline organs and parts of nervous system and circulatory system. The left lung is then going to have this impression for the heart within it. And again, there's 2 lobes named superior and inferior. Okay. There's a fissure that separates out these 2 lobes. The 3 on the right side, 3 lobes. Okay. Interestingly, the right lung is even shorter because the liver is pushing out. But now my question, and I don't think this is discussed in the textbook. What's the adaptive advantage? What was the advantage for having subdivisions of the lungs? Why aren't these just a right lung and a left lung? Why instead do you have 5 sections of your lungs? Right? 2 on the left, 3 on the right, 3 and 2. For those of you that had calculus, 3 and 2 is 5. So what's functional significance of this subdivision? And I would argue it's the same as why buildings have fire doors. So right now, when you go into Mayhem, there's doors into each lab, and they are generally, when we're not working and moving through them or ventilating out the rooms, we keep those doors closed. And you notice that if you're moving between alumni and mayhem, there are doors there that are always to be closed, and those are called fire doors. Well, if there's a fire in alumni, it's less likely to spread or spread quickly into mayhem if those fire doors are closed. There was a horrible fire in the news about a few weeks back, and I think it was in New York, in a horrible, tall housing apartment complex. And the fire spread quickly, and they found out later that the fire doors had not been closed. Well, like fire doors, if you have lobes to the lungs, then if there's an infection in one of these lobes, it doesn't spread easily to the others. It can, but it doesn't. That includes cancer, that includes any kind of tumor, that includes any kind of response, maybe to fungal infections or something like that. So just like there are subdivisions within muscles, and we said the same thing, slowing the spread of damage or disease. The slowing the spread of damage, disease, advantage in muscles being subdivided is the exact same thing for lungs. So lung subdivision slows the spread. The answer here slows the spread of damage and disease. Here now, one of the nice cadaver showing you then some of these distinctions. The fissures are the divisions between the lobes. Okay. Showing you both right and left side. And if you listen closely, that's Lucy's. She's breathing and she's by my feet. Here, the cardiac impression. I know, if I was in class right now, I would fold myself down into a little ball and I'd say, this is my cardiac impression. And no one would laugh. And so let's just get it over with. Here, the impression means how the heart pushes into the lungs and causes a deformation or a change in the shape of the lungs on the left side. And this is what we were saying about two lobes on the left side because it's more impacted by the heart, less so on the right side. So here's some of those names of the lobes, and here's now some of the names of the tubes that are bringing air to those lobes. So a main bronchus, and then here you can see the superior lobar, middle lobar, and inferior lobar. The lobar are the secondary bronchi. And I have to be honest, I use primary, secondary, and tertiary, and I don't use these names. I'm not quite sure what the advantage is to that. This is very simple and tells the story. The first branch makes primary. A branch off of the first branch makes a secondary. And a branch off of the second branch makes a tertiary. So within these branches, we call that the bronchial tree. We've already looked at the lining, and we said it was a pseudostratified columnar epithelium. And now, just so you know, as we branch more and more, and as the bronchi get smaller and smaller in diameter, the epithelium becomes more flattened, shorter, and eventually turns into something that's going to look like a simple squamous. Below the epithelium is a lamina propria, just like we saw within the digestive tract. Why do we have a lamina propria here in the same histology? Well, it's derived from the digestive tract, okay? The lamina propria below the epithelium is going to have mucus glands, also lymphatic structures, and once again, this is the same as the digestive tract. What's all the functional significance? This is all about helping the immune system respond to anything that's inhaled. I guess at this point I'm going to mention, maybe you've been waiting for it, that as we look at the lungs, this certainly is hugely the topic of the last couple of years with all of COVID and all the COVID cases largely being disease of the lungs. COVID, the virus, is being found in so many systems of the body. In some cases, turning into what's called long COVID, which is months and months of symptoms, sometimes over a year, and not easily treated, and we're still trying to understand it, but it looks like, the latest is, it looks like it's all a reaction of the immune system, and how the immune system is trying to cope with this virus found in all these different systems, making brain fog, making it difficult to think, and damaging potentially organs of the digestive tract and other parts of the body. So those of you that have had COVID and think you got over it quickly, there could be lasting negative effects. There are lasting negative effects. In fact, I just saw a report that simply enough, if you had COVID, you're much more likely to die in the next 6 months of something else just as well. So if you don't die of COVID, it might contribute to you dying of something else. So it speeds up, it really stresses other systems in your body. All right, so we're talking about the respiratory system. Is the list going to load us up then on how COVID affects the respiratory system? And the answer is no. Now, we're going through the healthy anatomy right now. Sometimes I'll add in other things, but I'll just let you know. This is the baseline. This is what you have to start with. What I'm talking about here, an understanding of the basic human anatomy phys of the respiratory tract before you get to have, if it's intellectually fun, learning about disease. So what goes wrong is medicine. Human anatomy phys is explaining to you the normal healthy situation. So it is way beyond this class to understand all that comes from COVID. But what I'm saying is, once we're through this and you've studied the respiratory tract, then if you read more about what COVID is really involving and how the lung is affected, it'll make more sense. And that's what it means to be educated. Okay? So, other things to know about the bronchial tree. There is elastic connective tissue. So these tubes, branches, bronchioles, primary, secondary, tertiary, all have an elasticity so they can expand or contract. And what that means is that there can be, when you inhale, a stretching of these connective tissues, and then as you exhale, they can then recoil and help to empty out the lungs. And that's where we're going to stop. We're going to stop essentially when we get down here, and this is called the terminal bronchiole, and that's where we're going to pick up our story because we're about to get to the functional part of the lungs, which is where gases are exchanged. And that's in these very thin-walled alveoli. And this is its own complicated story. You can see here the capillary bed that forms around the alveoli. And this takes some time to really understand the functional structure of this very special functional part of the lungs. So I'm going to stop here, and we'll pick up in Lecture 9, the alveoli.